Here's how we're breaking this down today. 1. The clinical case begins. 2. Ruling out a hernia. 3. Eliciting key clinical signs. 4. Reaching the diagnosis. And finally, next steps and surgery. Let's get into it.
Part 1. The clinical case begins. There's a reason they say a scrotal swelling is a make or break case. Look at this quote from our source material. This literally determines whether you pass your surgery rotation or not. Why? Because examiners absolutely love it. It tests your anatomy, your exam technique, and your logical reasoning all at the exact same time. You really can't fake your way through this one. So what's our ultimate goal here? We have to confidently differentiate between a purely scrotal swelling, meaning it's confined strictly down there, and an inguinoscrotal swelling, which starts way up in the inguinal canal and travels down, like a hernia. Literally everything we do from this point forward is to answer that one crucial question. All right, let's look at our patient. We've got a 36-year-old male presenting with a right-sided swelling he's had for about 6 months, along with this dull, dragging pain. But hey, pay super close attention to the negative history here. What the patient hasn't experienced is just as critical as what he has. No trauma? Boom, we can cross a hematocyl, a blood collection, off our list. No sudden pain or vomiting? That is absolutely massive because it helps us instantly rule out an acutely obstructed hernia, which, as we all know, would be a surgical emergency. Section 2. Ruling out a hernia. Now remember, you've got to examine these patients standing up first. On inspection, it's pretty obvious the right hemiscrotum is enlarged. And because all that fluid volume is stretching the skin out, the normal scrotal rugosities, those little wrinkles, are totally lost on the right side. The mass effect is even pushing the penis slightly to the left. But here is the real game changer. We ask the patient to cough and nothing. There is no cough impulse. An expansal cough impulse is the classic hallmark of a hernia. So losing those rugosities and seeing zero cough impulse, that tells us we're almost certainly dealing with something else entirely. But, we can't just stop at looking. To completely rule out that hernia, we have to ask one defining anatomical question. Can we get above the swelling? This is the ultimate physical test. Moving on to Section 3, eliciting key clinical signs. Okay, so how do we actually do this? You take your examining hand, place your thumb right in front of the upper part of the swelling, and your 4 fingers directly behind it. Then, you just gently pinch your fingers together, feeling for the spermatic cord. If this were a hernia, you'd feel a thick, bulky sac passing right between your fingers. But for our patient, we can clearly feel just the cord. The entire bulk of the swelling is sitting right below our fingers. The results? We can get above it. This is a brilliant clinical finding because it completely eliminates a hernia from our suspect list. We've officially isolated this thing strictly to the scrotum. So we know where it is, but what's actually inside it? Is it solid? Is it fluid? To figure this out, we test for fluctuation. Now, these swellings can be massive and super slippery, so fixing it first is an absolute must-do clinical trick. You firmly lock the swelling between the middle and ring fingers of one hand. That frees up your thumb and index finger to press into it. And remember, you've got to press in 2 distinct perpendicular axes. Push on one side, feel the fluid bow out against your other finger. That is positive fluctuation. And sure enough, our patient's swelling is strongly fluctuant. Now, while you're doing this, you're also trying to palpate the testicle itself. But in this case, the testicle is not palpable separately from the swelling. What does that mean? It tells us we've got a tense, fluid-filled balloon totally enveloping the testicle. All right, so it's fluid, but what kind of fluid are we talking about? Blood? Pus? Clear fluid? We answer that with transillumination. First, stretch the skin slightly just to make it taut. Next, kill the lights, make the room pitch black. Then, place your torch right against the skin. But here is the absolute secret to passing your exam. You must shine the torch laterally. Seriously, don't shine it medially and never from below. You have to go lateral so the solid testicle inside doesn't block your light beam and completely ruin the sign. And would you look at that? Beautiful, glowing transillumination. The light just shines right through it. This is absolutely crucial because it confirms our fluid isn't opaque like blood and it's not a solid mass like a tumor. It's a sac filled with thin, clear fluid. Which brings us to Section 4, reaching the diagnosis. We've done the work, we've gathered the clues, and based on that flawless step-by-step exam, we can confidently lock in our diagnosis, a right-sided primary vaginal hydrocele. Let's quickly recap how our checklist practically built this diagnosis for us.
We found clear fluid that transilluminated beautifully. That points straight to a hydrocele. The swelling was super tense, and the testis was completely enveloped and impossible to feel separately. Put that together, and it specifically points to a vaginal hydrocele, meaning the fluid is filling up that tunica vaginalis space right around the testicle.
Now, you might be wondering, why did we call it a primary hydrocele? Well, hydroceles basically come in two flavors. A secondary hydrocele is reacting to something else, like trauma, an infection, or even an underlying tumor. But think back to our very first history slide. Our guy had zero history of trauma, no sudden pain, no infections. Because of all those negatives, we can safely and confidently categorize this as a primary hydrocele.
Finally, Section 5, Next Steps and Surgery.
We've got the diagnosis, but before we can even think about the OR, we need our pre-op investigations. We order these for two main reasons. First, to officially back up our clinical findings. An ultrasound is fantastic here, just to confirm the fluid and, more importantly, make sure there isn't some tiny tumor hiding behind that tense sac that we just couldn't feel. And second, we have to make sure the patient is safe for surgery, which is exactly why we run routine viral markers and a clotting profile. Of course, your examiner is going to ask how you plan to fix this, so you've got to know the procedure. For a relatively large 6-month-old hydrocele like this one, Jaboulet's procedure is your definitive go-to. It basically involves making an incision, draining out all that clear fluid, and then surgically averting, literally turning inside out, the hydrocele sac. That way, the fluid can't ever accumulate in that space again.
And there you have it. You've successfully cracked a classic make-or-break surgical case. You nailed the primary vaginal hydrocele. But before we wrap up, let me leave you with this to chew on. You've mastered this presentation, right? But what if the very next patient walks in with a massive groin swelling that absolutely does not transilluminate, and no matter what you do, you cannot get above it? That changes the entire game. So how are you going to adapt your detective skills for that one? Keep examining, keep asking questions, and I'll see you next time.